Hi everyone, I'm Raman Srivastava, a fellow junior doctor working with Dr. Blackburn, an old-age psychiatrist from the University of British Columbia in Vancouver, Canada. This mini-gem is on late-life depression. Overall, we'd like you to learn how to recognize late-life depression, know when to refer, and understand the treatment approach. To start, how do you define late-life depression? Well, a recent review says it's a depressive disorder occurring in those over age 60. This includes people who develop de novo depression in old age, and those with recurrent depression who just got older. Standard diagnostic criteria like the DSMs or ICD-10s do apply, but the practicalities can be more complicated in the elderly. But how is late life depression different from early life depression? Well, late life depression is more chronic, with transient recoveries and frequent relapses. It's often accompanied by cognitive impairment, dementia, and other chronic medical conditions, all of which can complicate the diagnosis. Patient complaints are less commonly of depression, but rather of somatic, cognitive, and anhedonia-related symptoms. And its identification and treatment are heavily influenced by social factors, such as loss of social connectedness, family discord, financial problems, or recent bereavement. Why do we think late-life depression is particularly important? Well, depression is the WHO leading cause of worldwide disability, and it's the most common mental health problem in the elderly, so watch your inpatients especially. Furthermore, depressed elderly have worse medical outcomes, being more likely to have poor treatment adherence, higher healthcare utilization, longer hospital stays, and higher risks of serious illnesses like stroke and MI. Also, they have higher mortality mediated by both suicide and non-suicide risk factors. Finally, research is increasingly showing a link between depression and dementia. We know adult depression is a risk factor for later dementia, but geriatric depression may actually signal the onset of dementia, so beware. Here are some common psychiatric issues that can be associated with late-life depressive symptoms. Feel free to pause and peruse at your leisure. Besides psychiatry differentials, you should be especially aware of medical problems that can cause depression. There are many, and the most common are highlighted and include neurodegenerative disorders, vascular insults i.e. stroke, traumatic brain injury, endocrine or metabolic derangements, especially with thyroid, parathyroid, or the adrenals, and finally, autoimmune issues, infections, or cancers. Sometimes, depression can actually be expected. The DSM quotes that 25 to 40% of individuals with neurological conditions, such as Parkinson's, Huntington's, multiple sclerosis, stroke, and Alzheimer's, will develop marked depressive disturbance at some point during their course. Bereavement presents another challenge. How can you tell whether a grief response is normal or indicative of a more severe depression? Overall, the negative emotions in normal grief are centered around the lost person and can fluctuate. In depression, they're about the patient themselves and persistent. For example, in grief, someone suffering tends to have a sad mood that fluctuates, known as pangs of grief. In depression, sadness is more constant. While people suffering from grief may still have pockets of happiness and humor, people with depression have an inability to anticipate happiness with unrelenting self-criticism and pessimism. Finally, thoughts of dying in normal grief are more about wishing to be with the deceased, while in depression, they're about worthlessness and hopelessness more generally, not necessarily loss-related. So that's what late-life depression is, and as junior doctors, you'll often be the first physicians with the chance to recognize a patient at risk. Consider depression screening particularly if any of these alarm bells are present. Recurrent help-seeking behaviors or healthcare contacting, multiple diffuse symptoms or persistent vague medically unexplained complaints, recent bereavement, social isolation, or recent admission to long-term care. You can use easily Googleable screening tools like the straightforward Geriatric Depression Scale or the Cornell, if the patient has dementia. If your patient screens positive, use diagnostic criteria to assess for frank major depressive disorder. And remember, regardless of your screen, always ask about suicide. We know that asking does not lead to an increase in suicide or put the idea in someone's head, so while it's sometimes hard to do, it can save a life. Don't forget. Once you've identified late-life depression, you are well qualified to treat it. That said, remember that old-age psychiatrists are also available to help, and certain presentations of depression are sufficiently emergent or severe that you should definitely refer. Psychotic depression, bipolar depression, and suicidality all certainly warrant a consult, and some guidelines would also argue that severe depression and depression with comorbid dementia or substance abuse also warrant it. If you're at the treatment stage, there are a bunch of options, but we'd like to emphasize a few points. First, given polypharmacy and other risks, for only mild depression, psychotherapy is probably the best place to start. Even if you can't access it, there are many online resources to provide, and I'll reference a few at the end. Second, ECT may actually work better and be safer than drugs. It can be life-saving. Third, a drug choice should be based on guidelines, algorithms, and individual factors, such as previous efficacy, comorbidities, interactions, and side effects. If you're starting medication, follow the rule for everything in geriatrics. Start low, go slow, but go. For more specifics, there isn't great data in the elderly, but consensus guidelines say, start at half the normal adult dose and titrate. Aim to reach average therapeutic dose within 4 weeks. Change if there is no response after 4 weeks on maximum dose, and consider adjuncts. Medications share similar side effect profiles, with common reports involving nausea, constipation, or diarrhea, dizziness or headache, insomnia or sedation, and sexual dysfunction. In the elderly, though, we also need to be especially aware of a few things. There's a small increased risk of bleeding in SSRIs, especially combined with other agents like ASA or clopidogrel. There's SIADH, especially in SSRIs and SNRIs, so monitor the sodium. There are also variable degrees of anticholinergic effects, fall risks, QTC prolongation, more with citalopram and maybe escitalopram, and of course, drug-drug interactions. A few other points for specific agents. No paroxetine or fluoxetine in the elderly, period. Mirtazapine is often useful as sleep or appetite issues. TCAs are dangerous in overdose, anticholinergic, and likely best left for geripsych. And in Canada, we sometimes use bupropion, but for other countries we suggest that you consult your local guidelines. Here's a quick summary to wrap up. Pause and read. As promised, here are some resources for you to check out. Here are some references for further reading as needed. Hope this has all been useful, and all the best.